Welcome back everyone to Pinellas County CME. This month we're going to be discussing the wonderful world of poisonings and overdoses. The goals for this CME are to keep it simple, go over toxidromes, and review the protocols for overdose and poisoning. We will be discussing different possibilities for poisonings ranging from organophosphates to antidepressants and overdoses to substances such as cocaine and opioids. Let's start with the basics. BLS before ALS, right? Always. Once you arrive on scene, find the causes and clues and avoid exposure to any EMS personnel. The most important thing that we can do is follow the systematic approach and provide assistance in airway ventilation. What's the most usual overdose call that we run on? Is it life status questionable at a bus stop or a friend performing CPR with CPR instructions given? Opiates, whether it is fentanyl from China or black tar heroin or someone who took a bunch of Oxycontin, they're all going to present the same way. Shallow respirations, decreased pulses. Like we covered in January and February, as long as we follow that systematic approach, we won't miss any other possibilities. Just to make sure we are all on the same page with the systematic approach, let's discuss it. We start with a primary survey. We treat any immediate life threats. Airway. Is the airway patent? Is the patient breathing? Is it too fast or too slow? Circulation. Too fast, too slow, or none at all? Disability. Go through AVPU, and then exposure. What do I see on the patient's skin? What's the skin color? Is it moist? Is it dry? So obviously we know in this situation that it's an opioid overdose. This causes decreased respiratory drive. That is an immediate life threat and it needs to be addressed. So make sure you bring in all of your bags on every call. We want to go straight for the Narcan, right? No, we don't. Before we go straight for that Narcan, we want to fix the immediate life threat and work through our ABCs. So following that systematic approach, we know that we need to manage this patient's airway. All right. Let's say we go straight for the Narcan without checking the pupils or checking a blood sugar, and we don't BVM the patient because we know that this is an overdose. So the Narcan doesn't work, the person is still breathing at 4 times a minute, and then your patient codes. So during your cardiac arrest, you check a blood sugar and you find out that it's 9. Oops. No one wants to be there at that moment. So the best thing you can do is follow that systematic approach. Also, if for some reason you decide to intubate your patient that it is an overdose, please do not follow your intubation with Narcan. They will probably wake up and rip that tube out. So make sure before you give any medication to a patient that you are doing it for the right reason. Even if it's something like Narcan, we are not law enforcement and we are not bystanders. So we don't just give anybody who's suspected overdose Narcan. We have training and knowledge and tools so we can take our time, assess our patients, and manage the airway and make a decision on how we are going to administer that Narcan based on our findings. Remember, administration of Narcan intranasally is a BLS skill. 2 milligrams for the first dose, and you can repeat it once after 3 minutes as needed. For ALS, intravenous Narcan is 0.5 milligrams up to 4 milligrams. Okay, so what's next? Let's keep in mind that when we look at protocol M12, poisoning and overdose, it has a lot of information, and it tells you different sections in the MOMS to go for different presentations with your patient. Let's talk about a call when you have a patient who is complaining of withdrawals from alcohol or opiates that they used maybe the night before or right before we got on scene. Remember, our job is to serve the community, not to judge people. This can be difficult at times, but you have to put your game face on and remember that we are lucky enough to have the opportunity to be doing this job. Let's talk about a call when your patient is complaining of going through withdrawals from alcohol or opiates. They may have used them right before you got on scene or the night before. Remember, our job is to serve the community, not to judge people. This can be difficult at times, but sometimes you just have to put on your game face. And remember, we are all lucky enough to be doing this job. So some of our concerns for these patients is the stress being placed on their bodies, because true withdrawals will lead to seizures. Once you get the vital signs portion of the assessment, if your patient's heart rate is greater than 120 beats per minute and their systolic blood pressure is above 140, proper treatment is to give that patient 2.5 milligrams of midazolam IV or IM, followed by a second dose, if needed, every 3 to 5 minutes. Good history taking is important as well. Make sure you find out what the patient is withdrawing from. Patients that are going through benzodiazepine withdrawals have a higher chance of having a seizure, so be prepared. Now that we've reviewed opioid overdoses and withdrawals, we're going to talk about toxidromes. The first one we're going to talk about is sympathomimetics. Sympathomimetics invade the sympathetic nervous system. This is a range of drugs that are some legal and some illegal. This involves amphetamines, caffeine, PCP, methamphetamines, cocaine, and even albuterol. This chart can give you an idea of the signs and symptoms your patient might be experiencing. You're probably going to see a patient who is agitated and has a high heart rate. sweaty, fever, hypertension, parlor, or cool skin. The main thing that we can do for these patients is supportive care. Fluids will probably help them out so that they don't begin to overheat. If they potentially become violent, then you can give midazolam 2.5 milligrams IV or IM, and you can repeat once after 5 minutes. However, if they are actively violent, you can give 5 milligrams midazolam and repeat after 5 minutes if needed. If you do not have an IV, you can administer 10 milligrams intranasally, which is 5 milligrams per nair. If your patient is still trying to fight after 5 minutes, you can give them another 5 milligrams, which is 2.5 per nair. Keep in mind that this probably won't be for someone who drank too much coffee at Starbucks. This is more likely for a patient that's been awake for 3 days on methamphetamine. Most importantly, keep yourself and your crew safe. Let's continue our poison journey into cholinergics. Why is there a dumbbell on the screen? Well, I'm glad you asked. The signs and symptoms of somebody suffering from cholinergic reaction are going to be diarrhea, urination, pinpoint pupils, bradycardia, bronchorrhea, emesis, lacrimation, or salivation. This is going to be from an exposure to organophosphates, pesticides, carbamates, or nerve agents. This is not going to be a good day for your patient, so make sure you keep yourself safe and remove them from the exposure. Treatment for these patients is going to require a lot of atropine, depending on the amount of the exposure. When I say a lot, I mean 2 milligrams of atropine IV every 2 minutes until secretions are dry. Remember, our med bags only have 2 milligrams. Other treatment is to contact online med control for duodot utilization. And if they start to seize, you know what to do. Next, we will talk about anticholinergic medications like histamines, atropine, cyclic antidepressants, Jimsonweed, oxybutynin, phenothiazine, scopolamine. These patients will present with agitation, delirium, coma, pupils that are dilated, dry mouth, flushed skin, tachycardia, hypertension, fevers, and urinary retention. These patients will get general supportive care, and similar to sympathomimetic patients, potentially they can become violent. If this is the case, again, you will give 2.5 milligrams of midazolam IV or IM, repeated once after 5 minutes if needed. Violent patients will get 10 milligrams, followed by 5 milligrams after 5 minutes. This is going to be 2.5 per nair. I was lucky enough to have a great pharmacology teacher, so it still sticks in my head when we're talking about anticholinergics. Another way to remember the symptoms is mad as a hatter, blind as a bat, red as a beet, dry as a bone, and hot as Hades. I'm sure some of you remember hearing that the same way in pharmacology class. Next, we will cover acute dystonic reactions. This is caused by antipsychotics, antiemetics, and antidepressants. These patients will suffer from involuntary muscle contractions. They usually start in a single area, such as the foot, hand, or neck. It can worsen with stress, fatigue, or anxiety. In this case, we are talking about acute dystonic reactions. Keep in mind that some people can suffer from something called tardive dystonia, which is a longer-term effect. Symptoms are usually something like pill rolling or lip smacking. They can present similar, so get a good history on your patient before your treatment. Treatment for these individuals is going to be 50 milligrams of diphenhydramine, IV or IM, followed by 2.5 milligrams IV or IM. They can be repeated once after 5 minutes. Now we will talk about OC gas, also known as pepper spray. When a patient comes in contact with OC gas, it feels like the skin is burning, lots of coughing, spitting, and a runny nose. Before you get close to this patient, make sure that you are outside in open air or the area has been aired out. Now let's talk about OC gas, also known as pepper spray. When a patient comes in contact with OC gas, it feels like the skin is burning, lots of coughing, spitting, and runny nose. Before you get close to the patient, make sure you are in an open air area upwind or the area that the patient is in has been aired out. For treatment of this patient, try to take off as much of the contaminated clothing as possible and flush the skin or irritated area with sterile water. All right, that wraps up overdose and poisoning for this month. Stay safe out there.